as a kid with our pediatrician, and I mean, you weren't there for hours, but you were there for a long, maybe having a conversation with my mother, Gone are those days. So I think managed care helped destroy some of that, or as I like to call it, mismanaged care. I think, again, public perception around HIV and AIDS, that it's still the gays and the junkies, that other people are potentially vulnerable. I think people's doctors and other medical practitioners' discomfort with talking about sex and sexual health.
Especially to the GLBT community.
Especially the GLBT community. And I think, all of those things come into play with this. And, kind of a little sidebar on this, we're losing HIV specialists. Either they're getting older and retiring, they're not being able to make a living because so much of our folks are on Medicare or Medicaid, and the Medicaid reimbursement rates are so low, and there aren't new folks coming into this specialty. Never mind infectious disease, but HIV is a subset of that.
Right.
So I think there's going to be a real, hole emerging, and I'm thinking too, with the advent of the healthcare reform, that are going to bring more people into the system and pressure on the AIDS world to do this, identify people who are positive, test, and get them into treatment, is going to bring more people into an already kind of overburdened system. And again, Connecticut's not in a horrible place, but other places around the country, I mean, there's, I think, 12 states who have waiting lists on their AIDS drug assistance programs because of budget constraints. And the move will be for the federally qualified health centers. So there's a lot of money in the pipeline coming into the federally qualified health centers as healthcare reform ramps up. So, and we're concerned that there aren't going to be specialists that know how to treat HIV and AIDS. And how do we manage that? How do we make sure that there are qualified people? Because it can, for some people, it could be a relatively easy disease to treat. I mean, there's protocols set up about treatment regimens and stuff.
Sure.
But for people who have more complex health issues, because many people come with more complex health issues than just HIV.
Yeah.
And we have an aging population, and we have a population of newly infected older adults, over 50s.
That was something Sandy was mentioning, is in the numbers that they were collecting, the fastest growing group was the 50-plus segment.
Yep.
Folks that figured, well, at this point in my life, I can't get it.
Wrong.
It's a huge issue. I've actually done a couple of presentations with, did one with the area agencies on aging in South Central Connecticut with the caseworkers there around HIV and AIDS. So did a little HIV 101, HIV prevention, and talked about some of the statistics with both, the aging population, people already infected, and then the newly infected older adults. And there's really not been a lot of research done with that population, so we don't know a lot about what the effects of the HIV meds are on older adults, on older women who've gone through menopause, with all the sort of normal, if you can call them normal, other health issues that emerge as we get older, high blood pressure, diabetes, cholesterol,
There's
heart
been
disease.
this big focus on it being sort of a young adult disease.
Yep. And those folks are getting older.
Yeah.
Yeah, that's kind of scary, isn't it?
Because even if we look at the statistics in the state of Connecticut on people living with HIV who are even say 40 and older, that's a snapshot. That's at the time of diagnosis.
Right.
That's not how old they are now. So, if they got diagnosed 15 or 20 years ago, 10 years ago, 5 years ago, they're that much older than that. So I actually think we have an even older population of people with HIV in the state. Because they adjust those numbers as, unfortunately, as people die, so they're not included in people living with HIV. So, So, there's always more work to do.
And that's certainly the aging thing is got to be a problem as far as things like insurance go. covering meds and things, it's hard enough for people
Yep.
post-retirement that are trying to,
Yeah, so in some states you end up on the waiting list for assistance.
yeah.
Right. And there have been cases where, in some of those states, and unfortunately many of them are in the South, of people dying waiting to get on the AIDS Drug Assistance Program list. Knock on wood, Connecticut has a pretty healthy AIDS Drug Assistance Program. We have a lot of medications on the formulary. We have a really strong working relationship with the Department of Public Health and Department of Social Services, who kind of co-run that program. So we're, in a much better situation than other states are. But, I really feel for, my colleagues across the country who are struggling to make sure that their folks get some of the basic things that they need.
That's unfortunate. Certainly, I think in a lot of ways we're fairly lucky where we are. But
I guess that raises an interesting question in my head around the stigma of having HIV/AIDS and finding medical care, be it through doctors' offices or hospitals, or have we seen much of a problem with that? Or
we haven't heard too much of a problem. We actually just completed a statewide needs assessment, kind of through our statewide planning consortium, and the barriers to care, stigma. We didn't call it stigma, but fear of disclosing your status definitely was part of the mix, but it wasn't a huge piece. I mean, people's barrier to care tend more to be around transportation, being able to afford it.
Right.
Those types of things. Sometimes being homeless can be barriers to care for folks. But I think, we have a really pretty well-established sort of system of HIV and AIDS care. And when I say that, I mean it in a very broad way. Housing, support services, case management, prevention, healthcare. So that when people do become positive and find out their status, which actually, and they usually find out through their medical provider. It's not through the state-funded counseling and testing sites. They do identify some people, but the majority of people who get reported with HIV or AIDS are through their own medical provider. And I think what generally happens there is that people go to the doctor, they have some presenting problem, some presenting symptomology. Because again, they're not getting tested routinely. Doctor rules out everything else, person gets tested for HIV, find out they're positive, and then they get referred to whatever the local AIDS project is. The state's fairly well covered. I mean, the Northwest Corridor, there used to be an AIDS project there, but they folded, I think, 2 or 3 years ago. But folks in Waterbury Health Department is providing case management up in that area, up in Torrington. And now Independence Northwest, which is located in Naugatuck in the Valley, they have some dollars for housing subsidies so that people's providing a little bit of housing up there. There's never been any AIDS housing up in Litchfield County. So I think we have a fairly decent system out there. One of the issues, though, is that for about 25% of people who find out they're HIV positive, they get an AIDS diagnosis within a year because they're getting tested very late in their illness or in their disease. They contracted HIV whenever. It's been left untreated all this time. They test positive, and a year later they have an AIDS diagnosis. So again, that's why there's this real push to identify the people who are unaware for a whole host of reasons. One, to get people into care, because the earlier they get into care, the better their health outcomes are going to be. The less likely that they can potentially infect another person. So it also serves as a kind of a secondary prevention strategy.
Right. You don't pass it along.
Right.
Sure, that makes sense. How effective are the drugs? I mean, we've sort of gotten, myself included, somewhat complacent about this. Not really.
Yep.
I really can't say that I know as much as I probably should. How effective? And we do certainly. I know we have a drug cocktail that is somewhat
Yep.
effective, but
Well, it's actually called HART, highly effective antiretroviral therapy. And I think it gets better all the time. And again, HIV is very individualized,
Sure.
because people have different strains of the disease. So different drug combinations work better on different strains than others. And there's some one-a-day medications now that they're developing that combine 3 medications. So instead of where you used to have to take 3 meds, you can now take 1. So that helps a lot, because what happens with folks, too, because they have to take so many meds, they develop medication fatigue.
Sure.
People can develop a gag reflex because of having to take so many meds. And that impacts their quality of life and can impact their, HIV disease. But there are good medications out there, and we have, a number of really good doctors who've been involved in treating people with HIV for quite a long time, scattered around the state. And we know who they are and try to connect people with those folks because we want them to get the best possible care that they can.
Right. How about the AIDS vaccine? Has there been any progress?
I don't think so. I think there was a little blip on the radar screen over the past year, but I went to the International AIDS Conference in Toronto. That would have been 4 years ago, and the Bills were there, Bill Gates and Bill Clinton. And so people asked that question, where are we? And they've, I think as most people know, have done a tremendous amount of work and put a tremendous amount of money into both AIDS service and research. And they said we're a ways off. It's a very complex virus, very difficult to figure out how to fight it in a way that makes sense.
It's really funny because you see people are going to the moon today and they can't find the cure for this. It's...
Well, there's some, I wouldn't go so far as to call them conspiracy theorists, but I think there's some truth to this. I mean, because it was first seen in gay men, the government didn't really jump on it. This was who was in office? Reagan was in office, and through 7 years of his administration, he never even once uttered the word AIDS or HIV. It wasn't until after Rock Hudson, his good friend, died or went public with his HIV status. So there was a lot of inactivity, and there's actually, I have a PowerPoint presentation I use to kind of show the HIV and AIDS timeline in Connecticut, but it has national figures in it as well. And there's a quote from someone from the CDC back in the early 80s, and the quote is, when it began turning up in women and children, the public started paying attention. Up until then, it was just a gay disease, and it was easy for people to say, so what?
Right.
And that was the attitude then, what might have happened, what could have happened had the governmental response and the community response, been, had they jumped on it.
Right.
Another decade of research.
Right.
Sure.
Right. So, we were playing catch up.
Yeah.
From, the get-go, really, on so many levels, on the research level, on the healthcare level, on the service level, on the, perception level. And we